Ladies and gentlemen, thank you for joining us. I am really pleased to announce that we are going to interview Ms. Chelsea Kosht of Medtronic Corporation, learn a little bit about her company, a little bit about her, and we'll take it from there.
Perfect. Thank you, Steve, for the opportunity to talk with you on your podcast. I will say this is the first time I've been on a podcast. I listen to a lot, so excited to be part of this journey with you. So I guess before I get started, I wanted to give like a brief introduction of who I am and what I do with
Please.
Medtronic, if that works. Okay, perfect. So again, yeah, my name is Chelsea. I'm actually based out of Columbus, Ohio, so go Bucks. But with that being said, my role at Medtronic is I'm a therapy awareness consultant. So what I do is I get the opportunity to talk and educate the community directly about deep brain stimulation for Medtronic. So really what my job is about is working either directly with patients or directly with community physicians who might be treating patients with common movement disorders. So with that being said, a big thing that I focus on is direct patient education. So one thing we know, and Steve, you might know this already, is that essential tremor is the #1 movement disorder in the US. There's nearly 10 million patients in the US who have it, and not enough are getting a treatment plan for it. So either they don't know the right type of doctor to see, or two, they just figure that this is something maybe their parent had, maybe their grandparent had it, and they just have to live with it. And they don't know that there's other treatment options out there. So what I get to do is one of two options is direct communication with patient education. So whether that be through support groups or partnering with movement clinics to host events and talk about treatment options for those patients, whether that be DBS or learning about maybe some pharmaceutical options as well, to say, hey, what are some of those non-invasive options that we might want to try before a surgical option? Or what are those surgical options? And bringing a patient to an event so that they feel comfortable and ease anxiety about understanding what treatment options are out there. So that's a big part of what I get to do with patients. And then in terms of what I do directly with community healthcare providers, I always refer to it as like health HCPs. So excuse me if I say that, but what I get to do directly with them is, again, I work in deep brain stimulation, which is under neuromodulation. And I can kind of do a deep dive about how I got involved with neuromodulation in a few minutes, if you like. But deep brain stimulation is a treatment option. It's known as deep brain stimulation, and it can help patients with essential tremor, Parkinson's disease, epilepsy, and then it's also HDE indicated to help with dystonia and OCD. So today I'm going to focus on ET with you, but what we know is about 17 million patients fall into that bucket of being a patient who might potentially benefit from DBS. We know that not every one of those patients, obviously in that 17 million, we can help, and maybe they're not a candidate for DBS. But what I can tell you is that we've implanted at Medtronic over 180,000 implants worldwide.
Wow.
Yes. So that it's a big number. But think about that 17 million in the US, when you compare it to that 180,000 number, it's not that big. So really what I'm trying to do is get the word out to patients that deep brain stimulation might be an option that could help you with some of these common movement disorders, and understand what it looks like. What's that surgery? What's this treatment option? Well, I don't know if I'm ready for brain surgery. So really it's all about creating education for patients so that we can ease the anxiety around what treatment options are out there, and then also connecting those patients with what I call a movement disorder specialist, which is a type of neurologist that specializes in movement disorders. So that's who you worked with, I believe, how you got connected with understanding what DBS is. And I think that's the number one thing, that if I can do something really successful, it's connecting that one patient I might meet in the community. Maybe it's even at a family care doctor, where I can educate them about some of the treatment options like DBS, and let them know, hey, this patient might need to see someone who specializes in movement disorders, so they know about the options. So then that's step one to that patient learning about the treatment options out there, even if it's starting maybe on some of those non-invasive options first, but then they can learn about the other options out there and hopefully create hope, that there could be an answer that they can start feeling more like themselves instead of thinking about their movement disorder that they have on a day-to-day basis. So hopefully that helps kind of explain a little bit about what I do.
Yeah, wow, I didn't need to ask any questions. Just let you run with it. No, you've taught me some stuff. And by the way, for those of you out there in YouTube land or something, Chelsea and I first became acquainted when I was very pleased to give a talk to a group locally about my experience with DBS surgery. And I was smiling when you were bringing up the non-surgical options, because I tried them all. And it was just, for me, it was like, I put on 30 pounds from the propranolol, and I'm fortunately down about 15 of that, but I've still got a ways to go. But, I'm an
Well,
old
great
man.
job.
What are you going to do? Yeah, no, this is now you had mentioned, how did you get involved? I always find the whys fascinating. So how did you get involved
Yeah.
with Medtronic, and did you seek them out, or did they seek you out, or how did it work?
I think it was a little bit of both, and that's a great question. So I've always done marketing. I actually worked at a Fortune 500 company, worked at Cardinal Health and product management for a really long time. So I did upstream and downstream marketing, and I actually got involved. I helped with blood clot prevention. So think about it's called sequential compression devices. And it's something, maybe if you go in for surgery, those sleeves that go around your leg to prevent blood clots. It's really a big issue. For example, 1 in 1,000 women get it when they give birth. And the issue is there's not enough talk about how it can get prevented in the hospital. What I learned is I was in the office day in, day out. And what energized me was going out and working with my sales reps, working with the nurses, being boots on the ground running, and seeing how my product actually worked. Fast forward, and a few years, and I got the opportunity to actually get a field marketing role in neuromodulation. So deep brain stimulation is under neuromodulation. And what I did, I've been in neuromodulation for a little over 4 years now. And I started out actually in spinal cord stimulation. And that's spinal cord stimulation helps patients with chronic pain. Maybe they had a failed back surgery, they've got neuropathy. And I got connected with that because I'm actually from Dayton, Ohio,
Mhm.
and I was personally affected by the opioid crisis. So I had some family members who had some issues with that. And I had a close friend who actually had broken their back.
Ooh.
Relatively young, yes. And they kind of went down that path of opioids. They actually ended up getting implanted with spinal cord stimulation and completely changed their life around, got off pain meds completely, and kind of got back to getting the ability to see his kids again. And it was something I learned about. And I said, you know what, that is something I want to do. And this is why, because this helped save him and get him off of pain meds, which had really affected kind of the area I grew up in Dayton. So I got the opportunity to do exactly kind of what I'm doing now, is talking to patients, working with chronic pain patients, working with pain offices to talk about SCS as a treatment option. And really my goal behind that was I wanted to get patients off of pain drugs. Like that was always my goal. I feel like that excited me. But how I got into DBS is I have a good friend whose dad was diagnosed with Parkinson's. And she came to me and she said, "Hey, my dad's going to get implanted with DBS. He's going to get brain surgery." And I she's like, don't you do that? Like, aren't you in neuromodulation? And I said, I don't do that. I do spinal cord stimulation, but I do work with the neurosurgeons who perform that surgery. And I was like, I can connect you with a neurosurgeon so you can talk with them. She's a pharmacist. So like she asked all the questions. She did all the research. She knew all about the different drugs that her dad was taking. And they ended up feeling comfortable going forward and getting scheduled to get implanted with DBS. And he moved forward with that procedure. Ironically, it was during COVID. So it did get postponed a couple times because the world shut down. Fingers crossed we never have a blackout like that again. But it ended up giving, she said, like her dad back. It ended up giving him back a little bit of what Parkinson's took away. It helped really control, he had really bad tremors. It helped control that, helped control his stiffness and his rigidity. And he came to me and he said, "Chelsea, I know you do spinal cord stimulation," but he said, "Honestly, you should be able to talk to Parkinson's patients about this as a treatment option, because if you would have told me that this brain surgery was going to help me, I would have done this years ago if it was an option. If I could have got convinced that this is something that's going to make an impact." And so with that conversation, I actually ended up putting my eyes open to see if this would be a role open to talk about DBS as a treatment option. And it actually came that it's a brand new program that I'm part of, that they are exploring how we can educate more patients directly about DBS as a treatment option. And that's how I really got involved. It's that, hey, it started out as, again, being tied to SCS and then seeing someone very close to me have their dad get implanted with it and change their life. It was something I knew I wanted to be a part of. Like, it's no longer talking about preventing blood clots, which is cool, but it's really talking about not changing one person's lives, but changing their family's lives. And I think that's the neatest part of what I get to do, is hopefully, honestly, just provide hope for those patients.
Well, and I can attest to that. I realize that I'm somewhat out on the bell curve in terms of reduction of tremor and all of that, and that's fine. It's not perfect. I will say that we have had a few little hiccups along the way, but they've been able to, modulate things away, for lack of a better term. I feel wonderful. My wife cannot believe the change in my demeanor. I didn't realize I was, I'm 69 years old and I felt like I was 85. I was ready to just pack it in, take me, I'm ready to go. And then I had the surgery, and about a month after the surgery, I wake up one morning, you finally get over that malaise that happens due to the brain surgery. But once you get past all that, my energy level, everything has been going up. Forgot to turn something on there. Has been going up ever since, and to the point where my wife and I are working out 3 days a week or so when we can get to the gym, that type of thing, and strength, getting back some of the strength that I'd lost due to my sloth. And one of the points that I make in the intro episode of my podcast is that it's not just me that's affected. It is me, it is my family around, and then the family around them. So there's kind of a ripple effect taking place. And I think what you do is so important.
With ET versus Parkinson's is So there's 10 million patients, right, with estimated with essential tremor.
Mhm.
And there's a little over 3 million, maybe it's like 3.4, I think, with Parkinson's.
Right.
So there's this group of essential, and Parkinson's is hard. And I don't think anyone would disagree with that. And there's a lot of resources for Parkinson's patients. There's a lot of fundraising, there's a lot of different events. There's options for patients to maybe feel like they have more support. Essential tremor, there's not as many resources, and it's a bigger movement disorder. So a lot of these patients, what you find is it is a progressive disease. So over time, yes, it does get worse, but like what a lot of times is patients might not seek treatment at all. So they might be with their family care doctor, right? And then maybe you're trying one of those first line defense items. So you're trying propranolol, you're trying Premedine, and you think, hey, maybe this is working, maybe something's happening, but then maybe you're noticing you're getting really tired, you're getting really sleepy, and you're blaming this. Is this the meds? Is this the ET? Like, what is happening? Or why isn't this working as well? And then maybe you increase something else, and then maybe something like your heart rate drops.
Well,
And
you bring up a great point. For the first 3 weeks after we upped my dosage of propranolol, I felt really good. But then the effect just started wearing off. And my tremor came back and everything else. And it was, if you look up the side effects of propranolol, there was something like 45 of them listed. I had over 20. We're able to identify. And I know this because I cut everything out, literally cut everything out. And I've only been, putting back, this drug or that drug. The one drug I do take is hydrochlorothiazide, which is a water pill, basically. My blood pressure tends toward the high, and that's why I'm trying to lose the weight too. But it's I told Dr. Rashid when he brought up the whole idea of DBS surgery, and I think I said it out loud. I said, "There's no effing way that I'm ever going to do this surgery." But it just boiled down to, how do I want to live the next 20 years? Did I want to have this tremor? Did I want to be this miserable old man, into my hopefully 80s or 90s? And the answer was no. And that's what made me realize that, if there's a chance that I can, recover some of my abilities, I'm going for it. And that's in spite of, I don't know if you're familiar with it, but just like 2 months ago, 3 months ago, something called the Willem ball was introduced. Are you familiar with that at all?
I am. So I am not as well versed as maybe you are, but I have looked, and I'm curious, I guess, to see more and learn more about it, because
Mhm.
I would love, like for myself, what I think is beneficial for patients is, again, like an ET education event with all of the resources. So
Right.
not just DBS, but also some of these non-invasive options. But curious what you learned about that, or what information
Well,
you have.
and I did interview her for the podcast, and I'll send you links later on if you want to poke around. But there is kind of she put herself out there as the spokesperson for ET, and she's from Sydney, Australia, New South Wales. Anyway, her name is Janice Wilton. Anyway, she goes by the moniker Shaking Ann.
Okay,
And
she's on TikTok,
okay,
right?
there you go.
Yeah.
She's had very bad tremors since she was a very young child. And her children now are starting to show the same type of progression that she had. And basically, she was told, get used to it. And she finally decided, nothing's being done. And I agree with her there. I think the research into, um, the root cause of essential tremor, I just don't think, I think people look at it and say, eh, it could be this, it could be that, it could be so many things. We'll probably never understand, and they dismiss it. And that's kind of the feeling that I've gotten, which is why what you guys do is so important, because it's like the villain ball on steroids.
Yeah, well, and I think something, I guess, unique of how, even how I got to Medtronic, what I think they finally did is, yes, we were the first to market DBS. We're the number one most implanted device in the world. So I think that speaks volumes. But the first indication was in 1997 for essential tremor, and then also to help tremor in Parkinson's patients. The difference is where it actually is getting implanted for those patients, because a lot of times those ET patients might get misdiagnosed with Parkinson's, or vice versa. So like that's kind of a process they get over too. But finally, back in 2020, we came out with our Percept primary cell device. Now we also have our Percept rechargeable device, but it has something known as our brain sense technology. So it's our ability to actually read a patient's brain waves and see what movement symptoms are happening in and out of the clinic. So this is, yes, it's a huge advancement. We're learning more about the patient in and out of the clinic. So I think this is important because, I mean, just think about how many times do you see your movement disorder neurologist? Like how many appointments or how much time are you with them?
Yeah, 15, 20 minutes, and she runs you through the paces and that type of thing. And, after the first few things, it was clear that, they had me on the right track. So I happened to see her last week. And that was Dr. Amstel. And I won't see her for well, it's actually a little bit sooner because she's going to be going on maternity leave. But yeah, it won't be quite 6 months. But yeah, I mean, I think the next big advancement for me, like hopefully is this on the market yet, what you're talking about?
Yeah, so you do have the brain sense in your device as well.
Okay.
You have that technology. So it's learning what I asked that question because you're in your body 24/7 hours a day, right?
Mhm.
You are with yourself, you know what's happening. So when you go back and we're utilizing this brain sense, we're collecting all these data points when we're running sensing to understand more about the patient, right? So we're getting this objective data to learn and say, hey, how can we help this treat you better as a patient, right? We're getting this objective data and learning. The best way I always like to explain it to patients is like, think about an EKG. Like if you go to a cardiologist, they put those pads across your chest,
Mhm.
and they might be using that to check for say an irregular heartbeat, right? But if you're just looking at that patient, you might not know. So now with the brain sense data, you can actually see what's happening to the patient outside of the clinic, not just what's happening right then. So, hey, what was happening? I especially even thinking going back to Parkinson's patients, because it doesn't always happen as much with essential tremor patients, like at nighttime having issues. But if you're having trouble sleeping and you're having movement symptoms at nighttime, especially for Parkinson's patients, or you're getting stiff, you can look at what's happening at nighttime when they come back, and your movement disorder specialist can look at that data and say, hey, let's come up with a true treatment plan that is customizable to you. So using the simulation, but also understanding what type of medications you might need. What can we do for the whole picture? What is happening inside of your brain when you're out of the clinic? So instead of you just vocalizing it to the doctor where you might be frustrated, they can look and tap into this data and say, how can we utilize this to maybe improve this program for this particular patient,
So
so that we can adapt the data for them.
to make sure that I'm understanding this right, it's not like they're tapping in 24/7. It's just the brain sense is accumulating data. And then when I go in there, it's downloaded basically so that they can peruse and go through it. And
Yeah, exactly. So you don't have to run it 24/7. You don't have to have brain sensing on all the time. But if your clinician chooses to kind of use that for a certain period of time to kind of tap in for certain symptoms, they can. So when you come back, they can look and say, hey, how can we utilize this? And I think the neat thing is with the Percept family, like with what you have is any technology advancements we make, that's unlocked within a patient. They can unlock that with that business or with that device without having that surgery as more information comes out. So I can't reveal too much about that, but I'm excited because we're learning more about what's happening inside so we can, again, how can we make it better for the patient, better for programming? And it's just going to be, it's an exciting time to be part of DBS as a whole, especially at Medtronic right now.
Do you know what excites me about what you're saying is that I know that in roughly 5 years, they're going to have to replace this device. And I'm thinking about the advancements between now and then. You know, all you have to do is look at the electronics industry has undergone in the last 20 years. And it's like every 2 years is this generational change. And I'm kind of excited about, you know, what's coming next.
Yeah, no, it's definitely exciting because I always tell a patient, like, I know there's other options out there and you can think about it. But when you think about DBS or you think about Medtronic DBS, that there are other companies like Boston Scientific and Abbott do it, DBS as well. I won't get into the details around that, but Medtronic, yeah, we were the first to market this. So there's a lot of clinical studies, there's a lot of data out there. There's a lot of learnings over the past, God, it's been over 25 years now. Think about it, 1997 to it's 2024. So we have learned a lot. The device has gotten much smaller over time. We've gotten much better at how we utilize it. Something else to talk about with DBS is the actual leads that go inside of your brain. They're known as syncyte directional leads. So this is what I like to compare this to. If you have like a nice, like a fancy house and you have like the lights that can turn on and off, or you can dim a light on and off. I don't have that, but I will say for the first time now on these on syncyte directional leads, at the very end of the lead, there's little contacts, and that's what controls the electrical stimulation that helps control the movement disorder for the patient. And you can turn those contacts on and off, and they wrap all the way around the lead. They used to only face one way, so just here. Now you can kind of stimulate and shape the stimulation for each patient. So truly, every single patient has a different kind of setting, different program. You're not stuck with the same programs forever. Although some patients find one program they like and they stick with it. But it's something over time you can adjust this programming along with like it as the disease might progress or how it changes with each patient. So I think it's really neat. And I would totally challenge you to even meet with some of our engineers at Medtronic to talk about it, because
that would be fun.
The details much better and technical than I just did.
Well, no, you're actually doing a very understandable job because, you know, your audience is me, and people like me. So, you know, you need to talk. I'm not going to say down, but you have to talk on a level that we can understand without blowing us out of the water. And believe me, I appreciate that a little bit. And you've touched on it. Is Medtronic? Who are they? What all do they get in? How long have they been around?
Yeah.
One of the things that I found fascinating was when my surgeon, Dr. Hoyt, admitted that that they don't know why this device works. Is the bottom line, just that it does. So I think now maybe he was just being a little flippant. I don't know, but it was certainly news to me. Plus, they found out that, and correct me if I'm wrong, brain stimulation has been known about since the 1930s, 40s.
I'm not sure about that number. I don't know where again, he's a neurosurgeon, so he may know more about that than me. I know at Medtronic, the first implant was done in France in 1987. However, I'm sure, again, it goes back when they were looking for different treatment options, that a lot of the times they used to remove a piece of the brain, right? And
Yeah,
they knew by removing that, it helped with, again, either making the ET or like a central tremor disappear or help manage that Parkinson's patient. So I don't know and the details of when it started with the stimulation, and maybe I should know that. I just know around with Medtronic, 1987 was like that first implant date. So that might be another good question again, if you get an
how
engineer
scary was
on.
that? So we have less than 2 minutes before they shut us down. So what I'm going to do is thank the audience. Thank you. This for me has been fascinating. I hope you have enjoyed it as much as I have. We will have a part two to this interview and hopefully get it up at the same time we get up part one. So thank you very much. And Chelsea, it's so great that you could be here. I'm very pleased. You
Yeah.
are so professional. And with that, I'm going to say adios because I've got 46 seconds.
Okay,
I'm
perfect.
on a timer.
Awesome.
So I'll
I
send you a link.
appreciate it.
I'll send you a link and we can get back up and running in about 2 minutes.